Hi, this video is to help you with your upcoming consultation about your rhinoplasty. Now, there are a variety of reasons why people come in to have work done on their nose. Some people primarily just have cosmetic concerns. Maybe they don't like the hump on the bridge of their nose. They feel maybe the tip is too wide or it doesn't fit their face well. Then there's lots of little subtle things like maybe they don't like the shape of the nostrils to the side or maybe their nose over projects or under projects. So it might be for primarily cosmetic reasons. And for some patients, it's a combination of the appearance of the nose and also the ability to breathe. There may be a septal deviation. The septum is the cartilage that divides the two sides of your nose inside to make two separate nostrils. And honestly, in most people, there is some deviation. The septum may be more to one side than the other. You also may see that the nose is more crooked on the outside because of this. Other reasons why people may not be able to breathe as well is there may be some collapse or instability, like when you breathe in well. Some people will pinch off like that. So that's an external nasal valve collapse. And then there's also internal nasal valve collapse where right in here, this may be too tight when you suck in. So it's almost like a breathe right strip opens up your internal nasal valve to get more air through. So part of doing surgery may be to improve a pre-existing problem. And the other thing is that we may create some of those problems. When we make a nose smaller, whether it's in the bridge, whether it's work on the nostrils, whether it's work where the valves are here in the internal nasal valve, we can create those breathing problems. So typically when I'm doing surgery, even though somebody's priority may be the appearance of their nose, I want to try to do some maneuvers that will try to maximize their function or their breathing, knowing full well that making a nose smaller can negatively impact your ability to breathe. So a little bit of anatomy for you. This top portion of your nose here is bone, and I sort of think of it as kind of a bone bridge like this, and it attaches to bones on your face right here and up in here. Now this middle portion of your nose is cartilage, and again it's part the septum that goes down the center, and then there are upper lateral cartilages here and here, which I sort of think of as two sort of weak cartilages that create kind of an A-frame, like a roof line. And then down here at the tip, we have lower lateral cartilages that come here and come out into this area of the nose. Like a lot of people, sort of thought beforehand that the cartilage goes out to here, and that's not how the cartilage is. It does go back over here to the top. So it may be that the bones and the cartilage in the middle third of the nose causing hump right here is what bothers you. It may be the shape of these cartilages right here. It could be the angle that the nose comes off here. It might be the width of the nostrils. There are lots of different things that bother patients. And what is important for us is to realize that once we change one thing about your nose, we actually inadvertently may change the look of something else. So if we take a hump down, we may change what the tip looks like proportionately. If we under project the tip, we may make the hump or this portion of the nose look more full. So even though you may have some really discrete areas that you want to change, I may be mentioning some other areas just to keep the proportions more attractive. Like if we do take a high dorsum or a hump down here, we've then made a nose like this kind of look like a nose like this, and it might look wider on the frontal view. So by breaking the bones here and pushing things together, we can then narrow the nose, keeping it looking a little bit more like it did before we took the hump down. So hopefully that will make sense to you. Other things are inside the nose. The septum can be very curved or have a spur that can make breathing more difficult. And you also have turbinates, which are like little humidifiers in your nose, and those come out from the side up against kind of near the septum like this. And those get bigger and smaller based on normal cycle and maybe things like hay fever or perfumes or pollen or something like that that can make those guys puff up. So I may do some work on the turbinates as well to try to open up your airway. We don't take turbinates out because that can leave a nose too dry, but we may straighten the septum, support the nasal valves, and outfracture those turbinates, all in order to keep your breathing as good as possible or even improving it from your pre-op status. Now, when I do rhinoplasties, I like to make an incision underneath the nose right here. That's called the columella. And what that allows me to do is lift all the skin up so that I can actually see the cartilages and the bones in the nose. And I feel like I do a much better job of changing their shape, supporting them, adding some supportive grafts, things like that, under direct visualization. There are some doctors that only make the incisions inside the nose and sort of pull cartilage out and change it and then put it back in. There's nothing wrong with that technique. That's just not something I am really comfortable with for most patients, and I prefer to do them open. So during surgery, we go in sort of a stepwise fashion, depending on what our aesthetic goals are. And once we're done, we wash everything and redrape that skin. We'll also put some splints inside the nose and then some taped splints on the outside of the nose. We're going to have little teeny sutures right here on the skin, and then some dissolvable sutures up inside the nose that sometimes we take out or sometimes they just dissolve on their own. Most commonly, the splints inside, outside, and the sutures are going to be there for a week after your surgery. So we want to keep this dry. So we're kind of mean and we don't let you take a shower until your follow-up day that you're coming in, where we're going to take the splint off. You can get your hair professionally washed if that is really bothering you, but we really want to keep that splint dry. I have found that if I give people permission to take showers, it just feels so good. You'll stand in there forever, and then the steam from the shower can make that splint pop off, and we don't want that to happen prematurely. Once the splints are out from the inside and we take the splint off here, we're going to see a lot of swelling that accumulates where the splint used to be. So you'll probably be leaving our office a little more swollen than immediately after taking the splint off. And the swelling then goes down kind of like this. We do, if we're going to break bones, I usually go through a little puncture right here on the sides, and those incisions are almost impossible to see. And the little incision underneath here, once it gets stronger after a couple weeks, will start you on some scar care. But as the swelling goes down, there's definitely going to be some things you like and some things you don't like about your nose. The tip of your nose, which is usually pretty wiggly and rubbery right now, is going to feel a little bit more like a knuckle. It's going to be harder, and that firmness, there can be some firmness that stays forever because of some supporting grafts somebody might need. But typically it's going to take about a year or two before that softens up, and definition around the tip area may also take about a year or two to see those fine results, depending on how thick your skin is. So it does, I would say, change significantly in the first 6 months, and then less significantly in the second 6 months, mostly around this area here. We know that there may be some things that are palpable irregularities, like maybe you can feel little, maybe some bone irregularities. Sometimes over on this side, you can feel some sutures that need to dissolve. Cartilage, unfortunately, has some memory and the ability to kind of warp or change. So we may start off looking like things are straight, and then maybe over some time potentially see something change a little bit. I do think that for most rhinoplasties, I would say that hopefully we see nice improvement, but perfection can be difficult because there may be one little thing that looks a little asymmetric, maybe a little too full, maybe a little too flat. We do like to wait a good long time, at least a year, before we do any type of revisional surgery. And sometimes it's easier just to add maybe a touch of filler that we can inject to even some out that may last a couple of years, rather than going back for a whole other surgery. surgery. Again, there can also be some potential long-term breathing problems. We do maneuvers during surgery to try to improve that, but it might also be something that could potentially be worse after it's all said and done and healed. Now, during the healing process, once we take the splint off, we want to prevent anybody from punching you in the nose, so certain physical activities you want to avoid. Also, it's a good idea not to rest your glasses on your nose. If you do have to, I say move them around a lot. Use the type of glasses that have a little foot plate to them, and to be the super nerd, maybe you can tape them up here on the forehead so that they're sitting, not resting that weight on the glasses. So hopefully that helps you a little bit with surgery. Typically I do it under a general anesthetic. Depending if it's your first surgery or second surgery or third surgery on your nose, it may take longer, but I'm usually allowing about 4 hours for a primary rhinoplasty. And if this is a revision and the revision was done in the last, say, 7 or 8 years, please try to get an operative report from me. That can be extremely helpful. And if your last surgeon, if we can get some photos from them too, that can be very helpful as well. So I look forward to meeting you, and we'll talk soon. Bye, thanks.